Okay, we are so happy to have our next guest speak. Dr. Sangeeta Patti is going to be talking about hormone therapy in young adults with PMS, PCOS, and infertility, and she's going to have some cases. So Sangeeta Patti practiced obstetrics and gynecology in the Washington, D.C. and New York area for 13 years before opening an integrative medicine center in Orlando, Florida. She graduated at the top of her medical class at the University of Maryland School of Medicine in Baltimore and completed a residency at Georgetown University School of Medicine in Washington, D.C. She has worked extensively and internationally as medical director for a 350-employee not-for-profit organization in gender health on maternal mortality, maternal mortality reduction programs funded by the Gates Foundation. Dr. Patti is a multilingual and is renowned in her field. And she's done interviews domestically and internationally, has done workshops domestically and internationally. Dr. Patti's special interest and strengths has been helping healthcare providers learn how to put together and integrate into real practice the vast amount of information in the restorative medicine field. So let's welcome Dr. Patti. I know she's familiar to many of us, and we're glad she's here.
Thank you for being here. On a Friday afternoon, ready to learn. I say thank you, my friends, because we're all in a mission, right? To learn something about how to restore optimal function to the body so that it does what it's supposed to do, which is to keep us healthy and happy and energetic. So it's kind of late in the afternoon, so I'm just going to ask you for 1 minute to stand up, stretch, shake it out, shake. I know a lot of you out there, come on, shake. All right, breathe, sit down. When I see my patients, I actually show them this slide first. I tell them, you know, this is me. It isn't really me. When I tried to do that, I actually fell flat on my face. But this is how we want to feel. So if you come in with a diagnosis like PCOS or PMS or infertility, I want you to erase that because you can restore the body's function and allow it to heal. The goal today I want to focus on is to explore the approach that we've used with the 5-point model, which is aimed at underlying causes. And how did I get interested in causes? The same way you guys got interested in causes, because we watched the rise of pharmacy and surgery. We watched the spending much higher than most other countries, and the mortality rate under age 5, one of the highest. We've all been part of a program that has a pill for every pill, right? A sleeping pill that causes gastric bloating and a gastric bloating pill that causes the headache. At some point, you start looking at it and going, this is crazy. You know, the best illustration of this is our approach to fatigue, right? Fatigue is the #1 complaint in the United States. And our approach to this has amounted to energy drinks becoming one of the #1 drinks that have grown in the last 10 years in this country, right? Following intuition, right, around the world, what do people do in the afternoon, right? They nap. And Harvard has studies to prove that this actually works. But when we realize that that's how we were naturally made, our sleep cycle is diurnal. We're supposed to sleep a full 8 hours, and no, it doesn't decrease as we get older. And we're also supposed to have 2 sleep cycles. A 90-minute nap in the afternoon is usually the best solution for most people, if we could do it. We all came from a quest to follow a very high vibration path in medicine which was originally founded on certain intuitive principles, which I now seek, as do you. Discover and treat the cause, not just the effect, is going to be one of the main things, treating the whole person. And when I started really understanding what a physician as a teacher is, it gave the power back to the patient, because these patients, when they come in, I say, you know, let's write your top 3 intentions down. You will be in charge. I will be your guide. Because that way the patient doesn't come and say, well, the treatment that you gave me is not working, right? This concept of going back to intuitive principles over the last 15 years has been followed by watching ancient beliefs like the body as an energy field proving out in the scientific literature in the 21st century that the body has a huge electrical field around it. The electromagnetic field of the heart is actually 100,000 times more active than that of the brain. The heart controls the brain. You see what I'm standing in front of? Brain awakening. How does one awaken the brain? You must start in the heart. It is about love. It's about activating that part. How many of you lay your hands on the patients? We were sort of taught that you do that carefully, right? Many of us don't lay hands on patients anymore. It was in the ancient texts, but last year, at the end of the year, they published a randomized trial showing that babies who had contact actually turned on a significantly larger number of protective genes at 5 years out. So this was contact at birth. The human touch is a powerful, powerful thing. When we come in and shake hands with this patient and give them hope and give them compassion and tell them to throw out the labels they've been given because they have the power to turn that around, that ends up being one of the most powerful pieces of what we do as healers. So this necessity to get back to intuitive principles was the mother of the invention that got me out of practicing obstetrics full-time and gynecology to what I do today, which is to help people restore optimal function to their organs and cells so that they do what they're supposed to do. This consisted of having to expand the toolbox of options that were available. Too many tools, as you see. I won't go through all of them. And the interesting thing that happened, as a gynecologist, I started seeing patients 50, 45 and above, women. And last year, about 30 to 35% of our patients are men, and the age range is 7 to 90. And a good percentage of them are physicians, because physicians themselves are seeking what we're seeking. Where are you going to start with your restorative program? You will have to start with you, right? So using the model that we ended up using with that 5-point model, we ended up having about an 85% resolution over the 14 years of all the conditions that you see listed here, and almost a 90% discontinuation rate of most medications: cholesterol, psych meds, pain meds, sleep meds, reflux aids. The knowledge that allows us to pursue causes is to accept that whether we have weight gain or problem sleeping or problem staying awake or anxiety, that there's always an underlying cause that's manifesting this way. So if I end up gaining weight, I look up and say thank you, because with that thank you comes, hey, thank you for the opportunity for me to look at this and do something different. Those of you who heard Daniel Amen speak this morning, same thing. You take a look, you become aware that there's an opportunity in your brain. It's not it looks bad, it looks good. It's an opportunity. It's an opportunity for us to do something different, and it's motivating. So the same underlying imbalances cause disease, and we've been hearing about them all morning. So when we're faced with people who have symptoms and who are possibly on medications, we're looking for deficiencies and imbalances in multiple areas. As a gynecologist, I ended up starting with hormones and realized that all conditions are ultimately have some component of low hormones involved. Even in the teenagers that I'm seeing, which I'm seeing teenagers at a much greater rate than I ever did before, right? How many of you are finding that the younger people might be sicker than our generation, right? That's what we're seeing. And as we started looking, it's not true that they don't have hormonal imbalances, but the benefit with them is because of their age, we're able to correct things in a way that won't require hormone therapy to be used long term, right? You might correct it for a short period of time. So lower hormones is a crux of this. Low nutrition, especially magnesium and B vitamins, zinc, selenium, and iodine, and I'll show you that these, of course, we know from measurement. Toxins, I would say the most important detoxification mechanism that we are not utilizing fully is drinking 100 ounces of water a day. How many of you here think you came close to 100 ounces by the end of today? Because I know I didn't hit that. And the fact is that when we have more cortisol production chronically, we turn off the mechanisms to store water, so we end up losing more. So we need that mineralized water. So we tell everybody to take some water, lemon, salt, drink it all day. pH, heavy metals, electromagnetic fields. But I will tell you, obviously it was pretty easy for me to do those three. But it was my own illness and my own experience with parasites that I got in 2011 that made me realize the power of the mind. You know how I showed you that first picture of that woman jumping in the air? We tell everybody to imagine themselves that way. That thought process has a completely different set of neural pathways, neurotransmitters, chemicals that are secreted, and a whole different result. We have the science to show that. Then a thought process, maybe not. Maybe I have PCOS, and I looked on the internet and found out I won't be able to have children. It's a horrible diagnosis. So working with the joy in people's life and helping them to find joy and not have your life be a list of things to do. How many of us here have lists of things to do, right? Every day. It's a list. So, and then the last piece, which can't be overstressed, is body stress, which is related to lower oxygen tension in the microcirculation. So low oxygenation to the organs. So using this system, we got the results that we were talking about a little while ago. The key to this system is that you can measure each one of those things, but you're always looking not for a normal range, which is between 10th to the 90th percentile, like Dr. Rothenberg was talking about. We are looking for the 75th percentile and above. That is where your brain, your bone, your heart, your immune system, your adrenals, everything is supported the best. DHEAS, we're looking for a level of greater than 200 in the morning. The morning you wake up after 8 hours of sleep, you should be ready to jump up and wonder what the day is bringing for you, right? Rather than dragging yourself out of bed. We're looking for optimal levels again. Vitamin D, a level above 70 as opposed to 30 is associated with a 50% reduction in strokes and heart attacks, cancers. It's also related to a 50% increase in thyroid function because T3 is dependent upon that D3 to bind it into the nuclear site. It's kind of sad that these symptoms that we associate with PMS, which all of us have seen them, it's become something which is acceptable. The prevalence, pooled prevalence, is 48%. Florida Hospital says that almost 85% of American women experience this in the childbearing years. We know of women who actually miss work cyclically, right? Either because of a migraine or because of PMS. Is it normal? Is it normal to have those kind of symptoms at the end of the cycle? Absolutely not. That is a sign of an imbalance. The treatment goals in traditional medicine consist of relieving symptoms and impairing functional function, giving pain medications. The Royal College of OBGYN listed some of the regular treatments that are first line: contraceptives, SSRIs, micronized progesterone. I was really happy to see that on there. Cyclic estradiol, danazol, and GnRH analogs. How many of these treatments are aimed at treating a cause? And you try to treat someone with PMS with the contraceptive tablet, which actually is the number one thing that people use besides pain medications. What about pregnancy? What about getting to the bottom of why they had the issue in the first place? So what are the causes? The number one cause is going to end up being the excess of stress that we are all feeling with the chaos that's in the universe right now. The EMFs, the Wi-Fis, the bombardment. Did you hear Dr. Amen talk about one of the number one ways to reduce the brain stimulation and improve activity would be to turn off our devices, right? So we're not bombarded with 10,000 pieces of unnatural information. If we get naked and get out in the forest, we will be bombarded with 10,000 pieces of nature's information. Much more powerful. You ought to try it. The hormones that are consistently low are going to be on the adrenal thyroid axis, and progesterone is going to be at the top of it, because in young women, when their adrenals are low, the very first thing that goes is progesterone. In young men, when their adrenals are low, what's the very first thing that goes? It's progesterone. It's still progesterone. It'll show up on the pathway in many different places, but it's always going to be progesterone. In the nutrient area, low magnesium is a key. Omegas, and low water intake, as we talked about. The stress-related activities that result in extra use of our fuel tank, I like to call our hormones and nutrients our fuel tank. So when our phone buzzes, or we're exercising too hard, we're not oxygenating, we're dealing with too many commitments, we're using more fuel. So we need more fuel. How is that represented? That's represented best by heart rate variability. When our heart rate variability is on the top pathway, you're going to use more hormones and nutrients than if the heart rate variability is on the bottom pathway. The bottom pathway is associated with recovery of PMS, PCOS, cancers, diabetes, Alzheimer's, anxiety. You can imagine. You are preserving your reserve. And the wonderful thing about it is that there are now mechanisms that can take you from that top graph to that bottom graph within 30 to 60 seconds, not 30 to 60 minutes like meditation in the mind takes. So let's do a couple of cases. This is a 32-year-old. She had severe stress. She came to me many years ago. And she was having PMS and pain symptoms that were rated at about 7 out of 10. She was having 2 to 3 panic attacks a month. How many of you have seen that scenario? The panic attacks, right? I mean, that's like they go to the ER. Our local ER doctor sends them to us. He's finally recognized that it's probably a progesterone deficiency. They're usually not sleeping and consequently always have low energy. So energy is not something people associate with PMS, but it's almost always there because it's almost always related to hyperactivity of the nervous system. Other things you find in these patients are heavy bleeding, anemia, and of course, she was offered many of the standard things that we would have expected her to be offered. They didn't work. So we went over all the causes and started her treatment. The evaluation that we use is exactly based on the 5-point model. We got her serum hormones, day 21, before 8 a.m., functional intracellular nutritional analysis, interpreted to greater than 75th percentile, evaluated her pH, her exposure to electromagnetic fields, and her lifestyle. We always evaluate heart rate variability and teach them methods like heart-focused breath to get themselves into a coherent rhythm. We ask them to examine their life stresses, and we usually do some kind of exam on every single patient. I think that, one of the things I always used to tell people is don't depend on someone else to do an exam that you can do. So if we're going to prescribe things, we must physically touch the patient, do an exam. The list of hormones that we usually get and the panel we get is in your slides and your sticks, so you can see them. But it's basically looking at adrenal thyroid pathway, and we provided the literature to her with a 5-point written plan. But most importantly, as I was saying in the beginning, she was provided with hope and compassion, which is something that we can freely give, which is most likely, in my book, the most powerful thing that you can ever give a patient. So she was started on progesterone, slow release, micronized 12.5 milligrams, and told to titrate up every night until the anxiety attacks were gone completely. She was given magnesium glycinate and a form called ATA taurinate, which has penetration into the blood-brain barrier and has a better effect clinically on anything to do with the nervous system. And enteric-coated omega, simply because of the improvement in compliance and the need for less pills and absorption. So the thing to realize is those things were selected based upon the fact that they directly affect PMS. There's excellent data to show that, and directly affect the nervous system and anxiety. She was asked to put her water in a pitcher, 100 ounces, with pink salt and lemon, to practice heart-focused breath, which really has to do with just breathing slowly and holding a place of joy, and restorative breathing instead of an extra thing. So I always get asked, why do I use oral progesterone? If you have somebody who has high anxiety, sleep issues, any kind of nervous system activity that's excess, you are going to want to use oral progesterone because oral progesterone will support the adrenal pathway. The cream progesterone does not support it as well. She was taught how to bring her heart rate to the right place. And at week 8, her anxiety was down to 2 out of 10. Her pain was down to 2 out of 10. She had not one single panic attack, which she should have been having at least 4 panic attacks minimally, according to her history. She was on 50 milligrams of progesterone. That's really barely anything. She was sleeping 8 hours, and her energy was up a little bit, not greatly. Now, if she had been a 62-year-old woman, this would not have happened in week 8. This is what happens when you're treating somebody who's in a younger age group. Is she going to be stuck on that progesterone forever? No. As soon as she learns how to control her stress and her adrenal pathway is corrected, she's not going to need to keep on it. Most of the patients who are at that age come off of it. Her labs came back. Her progesterone, as expected, was 0. Her DHEAS was at 120, and it should have 138, and it should have been at 200. Her free T3 was 230, and that should be closer to the 400 range. They almost always have a thyroid function activity issue with it, but usually you can correct it by correcting the sleep and the nutrients. We did a functional test on her. The aim is greater than 75th percentile. She was low in the B vitamins, magnesium, and zinc. So we put her on a multivitamin, mineral. We're always looking for purity, right? no preservatives, vegetable capsule, no dye, colors, chemicals, active B vitamins because they're different from the B vitamins people have to activate. And you definitely want to make sure that you have thyroid, adrenal, and insulin activating doses of all the minerals, the zinc, the selenium, 400, chromium, cobalt to clear bad estrogens, antioxidant doses, forms of vitamins that are natural in the body. And what do we do at week 8? Because she's so much better, right? But she's not completely better. She's on 50 of progesterone, so we went ahead and increased the progesterone another 12.5 to 25 milligrams as needed. We added an essential multivitamin mineral. And if at week 12 her energy level has not come all the way back up to the 8-9 mark, you could give her some thyroid. Because it really has a lot to do with how well she does at learning how to correct her heart rate variability. This is a 20-year-old on oral contraceptive tablet, very common scenario with PMS, anxiety, and insomnia. The crux of this treatment, besides teaching them how to correct heart rate variability, is going to be low-dose oral progesterone titrated until symptoms are gone, an essential multivitamin, magnesium with the ATA in it, and enteric-coated omega. That regimen pretty much works for everybody. Are you going to disable the pill by giving progesterone? No. It's too weak. It cannot take away the contraceptive effect. 35-year-old with PMS, anxiety, insomnia. Progesterone was given at 12.5 milligrams, and again, the same regimen. So it doesn't matter whether or not they have a pill on board or not. The regimen pretty much is the same. And that's what the beauty of it is, right? I'm not telling you go out there and learn 10 different things. I'm saying learn how to correct those 5 areas, right? Magnesium, I call it a miracle because I've found out of everything, it's one of the things that ended up really helping me correct a lot of these things, especially when you use the taurinate forms. And you know that Dr. Sinatra also has always talked about this for ATP production. But I would say that magnesium deficiency is probably the #1 deficiency that I'm seeing when I measure things, because it's representative of the fact that our nervous system is overstimulated, right? The nervous system is overstimulated. And if you look at the pathway, you'll see why it induces anxiety when it's deficient and how it blocks nerve excitation. That's all on your stick. And also how it converts the beta waves to calmer waves. So the treatment for the PMS ends up being a little bit of each thing. Water, 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 joy, 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 oxygenate, take some nutrition, correct the adrenal and thyroid axis. And part of the correction is learning how to breathe and learning how to correct your heart rate variability. So that brings me to the next thing. This topic is dear to my heart because I see all the young women who come in having read about they won't be able to have children with this diagnosis. And of course, the first thing I do is say, let's not even put that diagnosis on paper. Let's not even write that down. Because what PCOS really is an imbalance in those 5 areas. The criteria are defined by NIH and many different things to include different factors. And the cases can be anything from very mild to very severe, but I can tell you that PCOS as a diagnosis is going up. It's not 1 out of 10 women as is documented in epidemiology. If you're in practice, you just see them coming through right and left with this diagnosis. And the common treatments are individualized, but they include a lot of medications and especially hormonal contraceptives. And what do you think PCOS patients want? They not only want a resolution of their symptoms, but they're also interested in having children usually. So the biggest fear is, how am I going to get pregnant, right? This is a 22-year-old who was diagnosed with PCOS. This is not her actual picture, but this is an actual patient. Her weight, she was 28 pounds up. Her energy was 5 out of 10. Do people usually look at energy and sleep in PCOS patients? No, but they always are low. They're always low. Metabolism is metabolism. Weight and energy go together. Amenorrhea, 2 years with no period, stress, not handled well, chin hair, and interrupted sleep. So really, if you take a full history, you'll find that they have a lot more symptoms than you think. Patient was offered metformin, the pill, medications, and told about the causes. Those are the causes that are listed in our books. These are the causes that we talked about. And the nice thing about these causes is that it empowers the patient because they know they can correct that, right? They can correct the cortisol progesterone pathway and the nutrition and the toxins. I mean, just drinking that 100 ounces of water flushes toxins, right? Even if you never even identified one, you'd be getting rid of over half of them. So in this patient with these symptoms, the labs that came back were representative of what we usually find. A high estrone, a progesterone of 0, a DHEAS of 126, which should be really above 250 for a person in this age group. So she has an adrenal dysfunction that's literally stealing the progesterone pathway. Low thyroid and a hemoglobin A1C of 6.2. Vitamin D being 18 means her thyroid can't work. So even if she doesn't have a huge thyroid dysfunction, she has a huge thyroid dysfunction. So we started her, in this case, we started her with metformin 500 milligrams BID, which we ended up stopping once we corrected other things. She was started on progesterone, slow release, 12.5, to titrate up to 8 hours of sleep, not to being over groggy, but to 8 hours of sleep. She was started on an essential multivitamin, the magnesium, enteric-coated omega, vitamin D of 10,000 units a day, and in her case, iodine. At that time, I used to do a skin patch test. I really don't know about that anymore, but most people are deficient in iodine when you do a 24-hour challenge test. So in these patients with cysts, I always use iodine. Whether it's a thyroid cyst, it's an ovarian cyst, it's a breast cyst, iodine seems to always have something to do with it. 100 ounces of water, heart-focused breathing that we talked about. I talked to you about why we lose water in adrenal insufficiency. We lose minerals. So, you know, it's kind of interesting. Suppose we never used hormones or never used any nutrient supplements, but we told everybody to drink 100 ounces of water with some salt and lemon in it, get in the sun, connect back to the earth, live in a place of joy, eat more vegetables. I think really what I've noticed, you really are going to reverse almost every disease there is. So it's very, very simple. Put her through the coherence training to teach her how to get her heart rate variability to a point where she's not draining herself and draining the adrenals. And in just 4 weeks, with such a low dose of progesterone, just 25 milligrams, that's as high as she got, her energy had come up to a 7 from a 5, and she was already sleeping 8 hours. So what we ended up doing at that point is adding a little bit of thyroid to the picture. This is necessary for these patients and infertility patients. At week 12, she came back 6 pounds lower. Energy level was a 9. She had had 1 period. This is after 2 years of having no period. Sleeping 8 hours. Her labs were better, but we found out that her triglycerides were 240 and her fasting insulin was 11. This is a very common scenario in these patients. So now we put her through what we do for people with elevated insulin. What we're really trying to do is take you from that curve on the red, which is swinging up high, putting on weight, swinging down low, having a hypoglycemic episode. If you have hypoglycemia, you always have hyperglycemia too. We want to bring them to the blue line. So we have a simple program. We basically put them through a 7-day veggie cleanse and then put them on a plate that I consider to be the best plate for all of us to be on for every meal, which is 50% vegetables, 1/4 protein, 1/4 complex carbohydrates. Always clean, 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 no GMOs, no pesticides. And we put her on a number of insulin sensitizers to try to help her receptor site become more sensitive. We put her on the essential multivitamin because there's excellent data showing that magnesium, vanadium, chromium, and a multiple B vitamins are associated with the insulin receptor. And at 6 months, she had lost 13 pounds, energy was corrected, she had had 3 periods consecutively. Her hemoglobin A1C had gone from a 6.2 to a 5.2. Her triglycerides had been cut in half. This is 12 weeks down the line. Vitamin D was up, and she was a happy camper. And this is not really her, but if you've treated these patients, you will note a huge difference between the beginning of treatment and the end of treatment. Weight gain has the same profile, so there's no difference. It's not like one thing's causing PMS and the other imbalances are causing PCOS. It's the same imbalances causing different things in different people. And this brings me to the last part of my topic, which is infertility. It's medically defined as the inability to become pregnant after 12 months of intercourse. They say that 6.7% of the population is infertile of women, but when you look at men and women, it's about 25% of all couples that has some kind of issue that has to be dealt with. Equally male and female. You always treat these patients as a couple because it's the field, right? What water are you drinking? What are you breathing? What is your life like? What is your stress like? How many of you have noticed that the incidence of premature ovarian failure is going up? Because I'm seeing this walk through the door all the time. What are the causes? There's some standard causes we talk about. Ovulation, fallopian tube, blockages, autoimmune, infections, enzyme deficiencies, genetics. What about thinking epigenetics, right? What turns those genes on and off? Why is it that those SNPs are not always related to a clinical outcome? Because we can turn them on and we can turn them off by correcting the field, right? Correcting the oxygen, the water, the structure of the water. That matters. Water has memory. We have great data showing the effect of toxins on human fertility, and great data showing the effect of radiation and cell phones on the same. Stress. I would say the number one factor in infertility is going to be stress. The minute you increase that stress by adding IVF and things like that, you actually decrease the fertility rate. And people I don't know how many of you are OBGYNs or take care of people who are going through IVF cycles, but it's miserable. It's absolutely miserable. So the thing to realize here, though, is that when I say that stress is such a big factor, it's because if the adrenal hormones are off, you automatically downregulate the receptor site of the thyroid, so then the thyroid doesn't work. And then you start to steal the hormones from the sex hormones. So you end up in a scenario where you feel like the sex hormones are off, but it's really because of stress-induced reduction on the cortisol pathway, because when the cortisol pathway suffers, everything gets shunted over. So you don't get pregnant with stress. And most of these patients come in on a medication. But they also have all the signs and symptoms of progesterone deficiency: lighter sleep, anxiety attacks, insomnia, mood swings, irritability, cyclic headaches and PMS, swelling, irritability. The normal treatments you guys are familiar with: surgery, sperm retrieval. But I'm going to tell you about what I use. So when I went to South India, I discovered this tree, and I took a picture of this tree. And this was the tree that people came and said a prayer and put their intention down to have a child. Does prayer and intention work? Yes, right? That's the base that you have to get each one of your patients to start with. No matter what they have, we have to set our intention down. Write it down. Sing it every day. Know that you can achieve it. And then we looked at the pathway, just like we looked at for the other cases that we saw. So this is a 32-year-old with hypothyroidism and infertility on 75 micrograms of Synthroid, which is T4. Her energy is a 4 out of 10. Is her thyroid corrected? She has brain fog, 4 out of 10. Is her thyroid corrected? She's been attempting pregnancy for 4 to 5 years. She cycles 25 to 45 days, and the infertility workup was negative except for the TSH. She's had 6 IUI cycles and tried Clomid. Her progesterone is 0. Is this a possible problem? It is. And in fact, when you give progesterone, the fertility doctors will say, oh, you're going to knock out our fertility treatments. Her DHEAS is 120. It should be above 250 at this age. This girl has an adrenal issue. Her free T3 is under the lower limit, so the thyroid is not corrected. The TSH is corrected by the Synthroid, but functionally she's not corrected, so she's not cycling. 25-OH vitamin D is 22, and we're looking for above 70. And she's iodine deficient. Now, having a cycle between 25 and 45 days means you're having anovulatory cycles. It's always couples therapy, always. So at week 0, she's given progesterone, 12.5, slow release to 75. She's also started on either a WP thyroid or, since she's already on Synthroid, 5 to 15 micrograms of T3, because you need both, and her T3 is low. She's put on the routine. It's nice to have a routine that you put people on, and then you measure and see whether or not it actually works. The essential multivitamin, magnesium, enteric-coated omega, 100 ounces of water and pink salt, heart-focused breathing, and joy. Now, this is the part that they always are coached as a couple, so they all are going to do this. It works better. It's kind of like the example Eamon gave this morning with the couple. Both did the program, and then they had success. Don't count and have sex 3 times a week. We taught them the coherence therapy. By week 4, the energy was a little better on the extra T3, but nothing else had changed. We're still headed in the right direction. Added a little bit more progesterone, went up to 50 milligrams, and added a little bit more T3. Immediate release. I'm not using slow release T3 here. This is not a patient with anxiety and heart palpitations, so you don't have to worry about using a slow release form of T3. You just monitor for anxiety and heart palpitations. The nutrition program has to be weighted heavily on measurement because you want this patient, when she gets pregnant, to have the nutritional reserve to have her genes and DNA in the right place, right? So pre-pregnancy. So we measured everything and made sure we had all the thyroid nutrients on board. At week 8, on 20 micrograms of T3, she still hasn't cycled, but her energy's quite a bit better. Mental fog's quite a bit better. Stress has been reduced. We increased again to 25 mics. At 16 weeks, her energy was a 9, her mental fog was an 8. She now had 2 cycles to talk about that were normal. We got some labs that showed that most of these things were corrected. At week 22, she reported that she was pregnant. I continued to take care of her until she delivered, because you always want to keep that T3 and T4 in the upper quartile, and what you'll find in most people is that they'll correct only the TSH, and it is related to the cognitive function in the offspring. This lady went on to have two more pregnancies after this, and she still sees me, but she didn't need any help with the other ones because all we've done is really correct the base. So when you start to see these young women come in with the 7 dwarfs of menopause, you know you're talking about a completely fixable problem, and using a system that's rather simple to use, which pursues, I would say, the most important thing, which is giving them hope, compassion, and love. And that's what I wish for all of you. Thank you very much.